Welcome to the 48th Lester Breslow Distinguished Lecture. I'm Ron Brookmeyer, Dean of the UCLA Fielding School of Public Health. We're here today to honor and celebrate the legacy of Dr. Lester Breslow, who is known to many as Mr. Public Health. He was an extraordinary public health leader, a widely renowned researcher, professor, and mentor, and the second dean of our School of Public Health. Throughout Dr. Breslow's public health career, which spanned more than 70 years, he had incredible impact. He made the powerful case for the importance of prevention. His groundbreaking findings linked healthy habits with living a longer life. Habits like exercising, getting enough sleep, eating well, and not smoking. His work provided key data linking smoking and lung cancer, arguably one of the greatest achievements of public health. Dr. Breslow held many important positions throughout his extraordinary career: president of the American Public Health Association, director of the California Public Health Department, and dean of the Fielding School of Public Health. His professional legacy lives on: the importance of evidence-based research, translation of research into real-world solutions, and the mentorship of tomorrow's public health leaders and change makers. And I'm so glad that Deborah Breslow is here with us today. Deborah was a partner in Lester's career, including his leadership here at the UCLA Fielding School, and remains dedicated to our school and to public health. Thank you, Deborah, for all that you do. Our school is celebrating its 60th anniversary this year, a little belated because of COVID-19. With 6 decades of impact, it is a fitting time to look back, pause, and reflect on how we got where we are today, the achievements and the challenges. This year's Lester Breslow Distinguished Lecturer, Dr. Abdelmonem A. Afifi, played a vital role in making our school what it is today during his incredible 57-plus year career. I want to share just a few things with you about Dr. Afifi. He is our school's longest-serving dean to date. Between service as acting and permanent dean, he led our school for 15 years. He served as head of biostatistics in the school. He is an extraordinary biostatistician, an expert in analyzing data and applying sound scientific principles. He designs and improves studies that will improve the health of populations. He has lectured throughout the world on biostatistical methods for designing and analyzing studies and how to address critical public health challenges. His renowned textbook, Practical Multivariate Analysis, is now in its 6th edition, known for its excellence, its practical and accessible approach. He is sought after on scientific and public health advisory panels for his wisdom. He has received many awards throughout his career, including elected Fellow of the American Statistical Association, recipient of the Mortimer Spiegelman Outstanding Biostatistician of the Year, and the American Public Health Association's Lowell Reed Award for Excellence in Teaching and Research. He is well known for his skill and dedication at mentoring and advising students, the next generation of public health leaders. And on a personal note, when I look to mentors and role models for myself, Dr. Afifi comes to my mind. A preeminent biostatistician, a friend and loyal colleague, he handles all situations, big and small, with the utmost of grace and respect. Dr. Afifi's lecture today will be followed by a Q&A session. We ask that you please submit your questions by clicking on the Q&A button near the bottom of your screen. I'm thrilled that he is here with us today to deliver his lecture, Reflections, Looking Back on a 57-year career at the UCLA Fielding School of Public Health. Please join me in welcoming Dr. Abdelmonem A. Afifi.
Thank you very much, Ron, for this very kind introduction and for inviting me to be the Breslow Lecturer for 2023. Also, thank you for suggesting the topic of my presentation today. I'm well aware of the illustrious Breslow lecturers who preceded me, and I'm truly humbled to be one of them today. I owe a great debt to Lester Breslow himself. Lester has been my mentor in so many ways, and from him, I learned what a great dean can be. Over the years, I watched Lester with admiration and saw how his tenure kept rising as Mr. Public Health nationally and internationally. My thanks also go to the late Dr. Ray Goodman, an alumnus of our school and the founder of the Lester Breslow Lectureship. Keeping with the tradition of previous Breslow lecturers, I will limit my presentation to 25 minutes or so in order to leave plenty of time for questions. I'll begin with recounting how the Fielding School of Public Health became an independent school. I'll then review my predecessor deans, and I will then conclude with a review of my 3 careers at the Fielding School as a methodological researcher, as a collaborator with other health sciences researchers, and as an administrator. The Fielding School of Public Health history goes back to 1943, when the University of California System-Wide School of Public Health was established in UC Berkeley. Shortly thereafter, UCLA became the southern branch of the UC School of Public Health and had a director to administer it. Over time, the UCLA branch expanded and became worthy of being an independent school with its own dean. In 1961, we became an independent school under the deanship of the late Dr. Steve Gerke, who had an illustrious career as a public health professional in the then Los Angeles City Health Department. It was Dean Gerke who hired me in 1965 as an assistant professor in the Division of Biostatistics. The school started with a single department, the Department of Public Health, with several divisions spanning the field as a whole. Its starting nucleus was the group of FTEs, that is the tenure track positions, who had before that constituted the Department of Home Economics at UCLA. The starting group of faculty of the school, who were either here at the time I came or joined the school shortly thereafter, include Virginia Clark, Will Dixon, Jean Dunn, Frank Massey in biostatistics, Larry Ash, Ralph Barr, John Chapman, Roger Dietels, and Telford Work in epidemiology, Ned Johns, Al Katz, and Ed Rada in health education, Milton and Ruth Romer, and Carl Hopkins in health services administration, Al Newman and Dick Jelliff in international health, and Alfred Slater, Rosalind Alfred Slater, Charlotte Newman, and Marian Swenside in nutrition. The first dean of the school was Dr. Steve Gerke, as I have just mentioned. He was the dean from 1961 to 1972. He was not only a consummate public health professional, but also an excellent dean who attracted many outstanding faculty and got the school started on a very strong footing. He was also a very personable colleague and hosted the whole faculty in his home once or twice a year because the school was small enough to feel like a family under his leadership. Lester Breslow was the dean from 1972 to 1980. It was during his tenure that our school established a firm national and international reputation, not only because of his name, but also because of his leadership. The school also expanded in terms of the allotted FTEs and approximately doubled in size. Dean Breslow showed by example how to do rigorous scientific research with an eye to the broader field of public health, practice locally, nationally, and internationally. Roger Dietels was dean from 1980 to 1985. He continued and expanded the path charted by Dean Breslow, paying special attention to attracting extramural research funds and continuing the hiring of stellar faculty. He was a strong advocate for the school. And as Ron mentioned, I then followed him from 1985 to 2000. I'll begin by reviewing my own career as a methodological researcher. In the next few slides, I'll summarize a selection of some of this research. My statistics PhD dissertation was on how to handle missing values in statistical applications. Bob Elishoff was my dissertation advisor at UC Berkeley. Together, we published 4 articles on the subject in the Journal of the American Statistical Association. We showed that mean substitution, common practice at the time, is a bad strategy for handling missing values. Instead, substituting values based on regression analysis using existing observations was a better strategy. This was a forerunner of what is now a standard method for dealing with missing values, namely multiple imputations, as formalized by Don Rubin and Rod Little. Bob Bendel was my doctoral student. We looked at various methods for variable selection and identified stepwise selection as the one with the best statistical property of those known at the time. This was a forerunner of more sophisticated methods, particularly the method known as lasso, which is now currently widely used for variable selection. Michael Costanza was also my doctoral student. We looked at stopping rules in forward stepwise selection. A partial list of my other methodological research areas includes multiple confidence intervals in linear models and survival analysis, longitudinal data analysis, exact and approximate tests for high dimensional tables, nearest neighbor and other clustering methods, and goodness of fit in generalized linear models. I'll now switch to research I did collaboratively with other health sciences professionals. Dr. Max Harry, known as Hal Weil, was directing the shock research unit located in the Los Angeles County General Hospital as part of the University of Southern California School of Medicine operations. The unit was treating critically ill patients who were in circulatory shock. Dr. Weil was one of the pioneers in setting up a computer monitoring system to continually measure a number of variables, including blood characteristics, intra-arterial blood pressures, and chemical compounds in the blood. Remember, that was 1966. He asked me to help him use these measurements taken at admission to quantify the prognosis of these patients. We used discriminant function analysis to identify the best risk factors to predict which patients will die and which are likely to survive. One of our earliest discoveries was that the most potent variable for prognosis is the arterial blood lactic acid concentration. Until today, this measurement is used in emergency rooms throughout the world to predict the prognosis of critically ill patients. We later expanded our research to develop a method for using the longitudinal data to update the prognosis procedure in real time. This work was an early step of what is common practice today, namely computer monitoring, not only in critical care units, but of patient care in general. Also, the use of discriminant analysis to handle patients' data was an example of applying what was later to be called logistic regression analysis. Experience with Dr. Weil was extremely valuable to me as a consultant in the medical and other health science fields for the rest of my career. As I mentioned, a running theme in my work is that I worked on things that later became mainstream. I'll now turn to another topic, namely, in the early 1970s, I worked with Dr. Morris Paulson of the UCLA Neuropsychiatric Institute to come to a better understanding of risk factors for parents who were child abusers. We used the Minnesota Multiphasic Personality Inventory, MMPI, as well as other instruments to derive skills for identifying parents who are likely to become child abusers so that appropriate intervention can take place and hopefully prevent their child abuse. Again, we use discriminant analysis for this purpose. At the time, it was a surprise for us to discover that being abused as a child was a risk factor for being a child abusing parent. Today, this is a well-known risk factor. In 1980, Lester Breslow obtained a grant from what was then called the Center for Disease Control to update the risk factors for heart disease in the United States. Lester asked me to be the senior statistician for the project. The group also included Jonathan Fielding, Axel Getz, and Coulson, Vika Heifetz, and Nora Valdivieso. We used data from the Framingham study and other sources. This was the first time that Framingham data were permitted to be used by an external group. Using logistic regression, identified those factors most responsible for heart disease, namely high blood pressure, high levels of LDL, low levels of HDL, diabetes, and obesity. These have become the standard agreed upon risk factors and were confirmed by many later studies. One of the highlights of this project was that we held a meeting in the Carter Library in Atlanta, Georgia, which was attended by President Carter himself. He stayed the whole day and was an active participant, asking many questions and making numerous comments. Over the years, I served as the senior statistician for quite a few other collaborative projects. For the sake of time, I will briefly describe a small selection of them, different types. My apologies to the many other outstanding researchers with whom I worked over the years for leaving them off the list. In 1976-77, I worked together with Dr. Leonard Sagan at the International Institute for Applied Systems Analysis, IASA, located near Vienna, Austria. We studied data from many countries around the world to identify the strongest predictors of health as measured by infant mortality and life expectancy in a given country. Our conclusion was that the strongest predictors were the level of literacy and level of energy consumption per capita in the country, in that order. Starting in the mid-90s, I worked with two epidemiologists, Lika Heifetz and Patricia Buffler, to examine the claims that the exposure to electric and magnetic fields causes dangerous health effects. Our conclusions were that there was no convincing evidence that such deleterious effects exist, with the exception of possibly a link between exposure to EMF and childhood leukemia, which remains an open question today. As you may be aware, a hospitalist is a dedicated inpatient physician who works exclusively in a hospital. In the early 2000s, the late Marie Cohen, then Dean of the UCLA School of Nursing, obtained a grant to examine the efficacy of having a multidisciplinary team composed of a hospitalist and an advanced practice nurse to improve health and reduce costs among hospitalized patients. Our research team concluded that, our research team also included Dr. Susan Ettner, Dr. Martin Shapiro, and Ms. Jenny Kotlerman. We concluded that indeed such an approach has a beneficial effect on improving health and reducing costs. For approximately a decade, starting around the year 2003, I worked with Dr. Christine DeRosa and Dr. Peter Kerndt of the LA County Department of Health Services, Bill Cumberland of our Department of Biostatistics, and others to explore whether middle school sex education courses promote a safer high school sexual experience. Outcome measures included use of condoms, prevention of sexually transmitted diseases, and prevention of unwanted pregnancies. It was concluded that such courses did indeed have some beneficial effects. For several years, in the early 2000s, I was the senior statistician of the Southern California Injury Prevention Research Center. I participated in a number of studies relating to injury prevention, working with the center director, Jess Krause, and other members, including Linda Bork and Billy Weiss. Together with Dr. Donald Maruski and Gerald Kaminsky and Jenny Kotlerman, we examined the effect of disease management programs on utilization of health services of various types in the state of Florida. We concluded that there is a beneficial effect of such effects. My final collaborative project thus far was to advise the Division of Glaucoma, the UCLA Geffen School of Medicine. I worked with Dr. Joseph Caprioli, the head of the division, the biostatistician, Fei Yu, and a number of others. We examined various ways of using longitudinal data collected from a large number of patients with and without glaucoma in order to improve the care of these patients, and explored ways to predict the onset of glaucoma before it happens to help with early treatment. I'll now switch to highlighting parts of my career as an administrator. In November of 1985, I was appointed as the acting dean of the Fielding School of Public Health, and in 1987 as the permanent dean. I served in that capacity until June 30, 2000. One of my first priorities was to improve the academic infrastructure of the school. Since we became an independent school in 1961, we had only one department with a number of divisions that varied over the years. As the school expanded and matured, it became clear that such an arrangement was untenable and that having multiple departments was the appropriate avenue to take. I appointed a multidisciplinary committee to examine the options, and we settled on the current structure of 5 departments. This arrangement was finalized in 1989 and has proved since then to be an appropriate structure for the school. In 1993, Executive Vice Chancellor Andrea Rich proposed the Professional Schools Restructuring Initiative plan. It called for closing some professional schools and combining some others. The School of Public Health was to be disestablished, that is closed, with the Departments of Biostatistics and Epidemiology to move to the School of Medicine, the Departments of Community Health Sciences and Health Services Administration to move to a new school called the School of Public Policy. And the fate of the Department of Environmental Health Sciences was to be decided. I was determined not to be known as the dean under whose watch the school was closed. The faculty and I decided to do our best to reverse this plan and keep the school alive. My own position was precarious because I clearly wanted to be part of the effort to save the school, but at the same time, I needed to stay in the background in order to keep the lines of communication open, to continue working with the upper administration after the school was saved. So the faculty and I decided to select the late Professor E. Richard, that is Rick Brown, to lead the effort to save the school. Under Rick's leadership and with the help from several students and alumni leaders, we mounted a national campaign to save the school. We called it Save Our School, SOS. We received a tremendous outpouring of support from the academic and practicing public health communities nationwide, and were indeed able to remain alive. In 1994, the UCLA upper administration decided to keep the school as is. The price was that the school had to withstand a budget cut, but we remained as an independent and vibrant school. To make up for the budget cut, I encouraged the faculty to become more entrepreneurial and increase their use of other faculty lines, including the in-residence and adjunct trajectories. The faculty did rally to the cause, and the school, in fact, became even stronger and rose in their rankings to be 7th in the US News and World Report rankings of the year 2000. And here's an example, a picture of a demonstration in front of Royce Hall that was taken by the late Professor Snehendu Kaur. This was a demonstration by our faculty, staff, and students. The CEPH accredits public health schools and programs in the United States and later in Canada and Mexico. In 1993, I was selected to serve as a member of the CEPH governing board, and I served in that capacity until 1998. Over the years, I was a member or chair of the accreditation teams for more than a dozen schools of public health until well into the 2000s. It was a very helpful experience that exposed me to the various models of having a school of public health. This experience helped me as a dean and also as a faculty member after I stepped down in the year 2000. Above all, I have been blessed with having had more than 200 outstanding doctoral students with whom I have served as either chair or member of their dissertation committee. Many of those went on to have illustrious careers in biostatistics and other parts of public health, as well as other scientific fields. I have also always enjoyed my experience as a teacher and was gratified by having had thousands of students in my classes over the years who appreciated my teaching. This sentiment was confirmed by some teaching awards that I received over the years. In summary, I loved all aspects of my career at the UCLA Fielding School of Public Health, and I was thrilled to be asked by Dean Brookmeyer to talk about that today.
Thank you. That was terrific. Thank you, Dr. Afifi. And affectionately, I know I call you Afifi, so if I may do that. But thank you so much for that perspective. And I just want to remind our audience that you can ask your questions through the Q&A chat. And while those questions are coming in, I'd like to start off with my first question for you, which I was really taken about the events around 1993 when there were attempts to close down the School of Public Health, and the incredible efforts that were made to keep the school and make it what it is today. My question is, reflecting back on that experience, what do you think the lessons learned for today about how to deal with challenges in academic public health, and what are the takeaways that can help guide us as we meet the challenges of today?
There are some good things that happened since then, and some things that unfortunately have not changed. Academically, the field of public health has blossoms. The number of schools, accredited schools of public health, has probably more than tripled. I haven't looked at the most recent numbers. And the number of programs is huge altogether, like they are now in the hundreds between schools and programs of public health. At the time I was dean, there were less than 100 altogether. Awareness of the field has really increased, and especially with the COVID pandemic, people have really become aware of that there is something called public health, and it is important. So all of that, I would say, is positive change. What has not changed is the support that the government gives to public health schools and public health organizations, both the state and federal governments. With all the efforts during the COVID years to increase the funding for prevention, for looking ahead instead of instead of reacting to disasters, have really not resulted in much change in the budgeting for public health organizations. So I would say, like I said, this is both a positive and a negative picture. But overall, I would say, at least academically, the field that has become more vibrant and better known, with many schools now offering undergraduate programs as well.
Great, thank you. We have an audience question that also speaks to some of the challenges, not only, as you mentioned, some of the resource challenges and attention that public health needs to get, but it also connects with some of the challenges we faced recently with COVID-19. The question is, given the attacks on science, especially the attacks on public health scientists, in some cases by prominent leaders, what advice do you have for young investigators now considering entering the field of public health?
I'm reminded of something that the late Professor Chuck Lewis, who was also in our school, the Department of Health Services Administration was called at the time, Health Policy and Management today. The irony is that when we do our job well in public health, no one is aware that we're doing our job well because there are no problems to talk about, which is the opposite of if you in medicine, there's a problem, then the doctor is like the savior. The best advice that I could give to people considering entering the field of public health is to really not expect to have instant rewards, and be conscious that your rewards will come from you yourself, knowing that you're doing the right thing, and realizing that an ounce of prevention is better than a pound of cure, and also working with your colleagues. The rewards are those that you get from being in such a community that has these ideals of not just protecting, but also promoting health in so many ways. And so that really is my best advice, is be ready to be satisfied with knowing that you're doing your job well.
Great. Thank you. Another question from the audience. What do you see are the most pressing challenges facing any school of public health, including the Fielding School? What should our priorities be as a leading school of public health in the coming years?
I think we already have had that question on our minds ever since the school started, and that is to emphasize all aspects of public health. The quantitative part, the behavioral part, the administrative part, and the biological and life science parts of the work, and the environmental aspects of it. So continue to be broadly representative of all those aspects. That's academically inside the school. And at the same time, be in close contact with the community as a whole, and be judicious in which things to look at in order to concentrate on those. There are still problems with having uneven distribution of wellness among different ethnic groups. A shameful thing is that the health of African Americans remains behind the health of other groups around the country. So we need to continue to promote, to concentrate a lot of our work on that. And also to make ourselves better known. And that has been the biggest challenge, how to make others, especially people in policy positions, and the general public be aware of who we are and what we do and how important our work is. That health is not just doctors and nurses and dentists. That our work, on the contrary, and the achievements, the expansion, the rise of life expectancy, for example, many people say it's attributable to improvements in medicine. Not true. It is improvements in public health that should be given the credit for the vast improvement in health of the community as a whole today. It's not just the improvement in medicine, that of course is also very important. And that, like Lester himself used to say, it's not that public health is part of medicine, it's the contrary. Medicine is part of public health. So that's what I would say.
Yeah. You know, one of the themes that I heard coming through is how, you know, all parts of our school contribute to solving public health problems. You know, we have 5 departments, and that, you know, public health really is a team sport where there's a lot of contributions coming from different sciences and disciplines. I noticed that you mentioned that we only had 1 department at one point. We didn't have the 5 departments. And I wonder how that, you know, as you reflect the changing structure within a school of public health and the departmentalization and so on, how does that, how do we continue to work across departmental lines and break down silos and all work together in a collaborative way? And I know collaboration was really an important theme of the work that you do. How do we grow that and grow that spirit of all working together and looking at problems from different lenses?
Okay, to go back, the detrimental effects of having a single department were not so much having to do with collaboration, etc. It was having to do with the nuts and bolts of promotion and you know, the process of reviewing and increasing, or you know, giving people a higher rank, you know, going from assistant to associate and so on and so forth. At that time, it was necessarily the situation at UCLA, for example, when someone was up for tenure, that the whole faculty would vote on that. And it was really very difficult for somebody in some area like, I don't know, biostatistics to correctly evaluate the work of somebody, say, in environmental health sciences. These are very technical things. So it was those nuts and bolts that needed to be changed. But the whole collaborative effort was not harmed, I would say, by our becoming departmentalized. We continued to be among the most collaborative organizations within the university. And that's typically the case. Schools of public health are just by their very nature multidisciplinary. Mm-hmm. And from my own looking at different schools, as I said, with the CEPH and so on, and just knowing what's happening, it is in our very nature to work together. Sometimes there is a little bit of a silo effect, and we just need to stay alert to that. And whenever we notice it, we need to work on it, you know, carefully and delicately, because those who prefer the silos don't want to hear the other arguments. But I don't think we have really a problem with that. I think we continue to be very much interdisciplinary, and we just need to guard against retrograde efforts that might come up once in a while.
question from the audience. How do you see the role of biostatistics and data evolving in public health? And really, there's been an incredible explosion with, data science and big data and data coming from social media and all sorts of different sources. How do you see that? What is the future for all this and its role in public health?
I think this is a really important question for the field of biostatistics. So many people have been encroaching on how to analyze data. What was considered the domain of biostatistics has now been, I should say, invaded by people from so many other fields. And people, the so-called data science, is still an evolving area. It's not clear exactly what that is. You talk to somebody in one area, one field of UCLA, I'd like to say, I don't know, management, school management or school education. It's almost everywhere. There's somebody that calls himself or herself data scientist without having necessarily had the quantitative training and the correct way of thinking about how to do data analysis. We need to be really alert to that and protect our role in that growing field, and make sure that as data science gels as an independent field or as a field, that biostatistics remains as a big part of it. We are doing that ourselves, and as you know, Ron, the Department of Biostatistics is starting a program of a master's in data science for the health sciences practitioners. So that's the kind of thing that we need to keep doing, and just be very alert not to be left out of such efforts on our own campus and also in general. I don't know how it's going to go, but it is evolving, and we just need to be very alert to what's going on with that.
Great, thank you. Another question coming in from the audience, and you talked about the three different pillars of your career, and the question has to do about what was the rewarding and challenging aspects when you switched from being a statistician, research, methodology, collaboration, and switching to being an administrator. How was that experience for you in terms of challenges and rewards and stresses?
Yeah. Well, to start with, I never had a course on how to be a dean, and nobody ever does. And the typical thing is that you get somebody who's successful in their own field or her own field, and then they become administrators. And the other thing that happened immediately is that instead of being just one of the guys in the school, I became them. I became part of the administration, and the faculty is us.
Does that mean you had to eat lunch by yourself?
Yes, or with
other administrators.
With other administrators, yeah. Exactly. You are well aware of that, I'm sure. So to be aware that this is going to happen was not something I had expected. But so I had to develop ways of continuing to be in touch with the faculty and continuing to make them aware I'm still one of the guys, So that was one thing. That was a challenge. The reward was doing something that then was beneficial, I hope, to the whole school, rather than just to my department, my division at the time, and being sort of the liaison between the external environment and the internal environment, and the external environment being the rest of the campus, but also the other parts of public health around the country. So I realized that, you know, my own view of leadership was to be exactly that, the liaison between these two environments, the internal and the external. And in time, I think I learned how to do that a little bit. And it was actually after the school survived the effort to close it, I felt so gratified with how the whole field of public health worked with us to make that happen. And I was really gratified to have been part of that. And although I wanted to stop after 10 years of being dean, it was so close to that whole thing. And I was advised by several of my close colleagues and confidants, it would be a bit dangerous to step down so soon after, because who knows what will happen if I did. So that's why I accepted to take a third term, and that's how I got to 15 years instead of the 10 that I had in mind. So overall, then the rewards was knowing what lies outside of immediate biostatistics environment and how to make that work for us. And but I then was very happy to come back and be part of the department again for another, I don't know, until now, another 20 years.
Well, certainly those efforts that saved the school affected all of us, and that's why we're all here today celebrating six plus decades. So another question from the audience. Can you share your thoughts about what you think the future of educational collaborations with other health sciences schools might look like? How can we connect better with nursing and medicine and dentistry and increase educational collaborations?
I think our connection with the School of Medicine was always and will continue to be very strong. Many of our faculty, I would say, do have some sort of connection with part of the School of Medicine, and the School of Medicine appreciates very much our contributions whenever they need them. Probably we need to do a little better with how we do our work with the School of Dentistry. We need to increase that collaboration a bit. The School of Dentistry doesn't have a strong research history as the School of Medicine. So we would do well to help them make that aspect of their school better. We, meaning we in public health. The other is the School of Nursing, and Dean Cohen, who sadly died prematurely, really got the School of Nursing to look at research better, and we in the school did help her with that work as well. Several of our faculty collaborate with nursing, but again, that needs to be strengthened a bit. So that's what I would say. Nursing and dentistry, we need to up our collaboration a bit. Medicine is going very well. We need to just be sure that it doesn't falter.
As another question came in, is there one area of public health that we should be focusing more on, both the public should be more aware of, that we as a school should be putting more emphasis on in the coming years?
The thing that jumps to my mind immediately is infectious diseases. In beginning in the 1960s and going into the 70s, 80s, and 90s, the switch from concentrating on infectious disease, which was what was happening from, say, 1850 until around 1950, we then recognized that chronic diseases are more, the thing that we need to worry about. But with what happened with COVID, and not just COVID, but so many other emerging infections, perhaps we need to concentrate on that a little bit more than we have been since the 1970s. The other is again the inequality of the levels of health, as I mentioned, that needs to be continuing as an effort. Every time you look at something, you see that, especially the Blacks, their level of health is not as good as it's supposed to be, not just in general life expectancy and mortality, almost any measure of health. The African American sector jumps out that they need help. So we need to continue to concentrate on that. And then overall, as I mentioned earlier, be more adept at publicizing what we are and the importance of what we do.
We have time just for one more question, and careers are not a straight line, and it's really hard to predict what direction a career will take, and you've contributed in so many different aspects. And several questions have come in about for new young people entering the field. From your perspective, what advice would you give them as they start their career and knowing all the ups and downs they're going to face? And I know I got to tell you, when I became dean, I came to your office and I asked you for your advice, and you gave me some really good ones, by the way, that I come back to. So thank you for that. But now, for young folks, students entering the field, what advice would you offer them?
I think number one, be sure to know what is public health. How do we differentiate ourselves from other health areas? And the emphasis on the population health rather than the individual health. Number one. Number two, start right away being interdisciplinary. Be in contact with other students from other areas, departments, if that's the way it's structured. And also, what I used to say to incoming students when I was deemed to introduce, the orientation, look around at the campus, and there are so many things happening, and you need to really take advantage of the tremendous opportunities that exist, not just scientifically and academically, but culturally. LA is a bliss to live in. All sorts of cultural and arts and opportunities. Take advantage of all that. It will get you in practice on how to be a collaborative public health worker in the future.
Great. Well, that's good advice for all. Take advantage of opportunities, collaborate. That advice will be helpful to many. So on that note, I want to thank you, Afifi. I can't thank you enough for being with us today and delivering your lecture, and also thank you for your incredible service to our school over the last 6 decades. I want to thank all of you for joining us today and being a part of this and paying tribute to also the enduring legacy of Dr. Lester Breslow. Have a wonderful afternoon, everyone, and thank you again for coming, and take care. And it was great to see you.